Assalam-o-alaikum. My name is Atta Babar and I welcome you to my YouTube channel. Today we will be discussing about pathophysiology of diabetes. In pathophysiology we will discuss normal carbohydrate metabolism, normal insulin action, insulin resistance, metabolic syndrome and incretin effect. Let's start with the normal carbohydrate metabolism. You all know that glucose is the fuel source of the body that is stored in liver and muscle as glycogen. If excess of glucose is present in the body, then it will be stored in the adipose tissue, which then undergo lipolysis that yield fatty acids. These fatty acids in the fasting state supply more energy to the body, except the central nervous system that requires glucose. Glucose is needed for proper function of central nervous system. Proteins can also be converted into the glucose through gluconeogenesis. In severe cases of fasting state, body reserves are used, that is the protein. Insulin and glucagon are produced by the pancreas by different cells. Insulin is produced by beta cells and glucagon is produced by alpha cells. These cells are called islets of Langerhans and these make up of 70 to 90% of the islets. Amylin is also produced adjacent to the insulin through the beta cells. As you all know, the normal insulin function is to reduce blood glucose levels. Glucagon has a counter action as compared to the insulin, along with counter-regulatory hormones such as cortisol and epinephrine. Glucagon increases the blood glucose levels. In different conditions, blood glucose levels vary. The counter-regulatory effects of glucagon and insulin and some counter-regulatory hormones maintain the fasting blood glucose value between 79 to 99 mg per deciliter. Now move toward the normal insulin action. During the fasting, insulin levels in the circulation average from 43 to 186 picomole per liter. After the food is consumed, the glucose levels and insulin levels increase. The release of insulin occurs in two phases. The first will be the initial burst. In the initial burst, this is known as first phase insulin response and it lasts for approximately 5 to 10 minutes and this serves hepatic glucose production and cause insulin mediated glucose disposal in the adipose tissue. This means the glucose production from the glycogen in the liver will stop and the glucose will move to adipose tissue. First phase insulin response minimizes the hyperglycemia during the meals and during the postprandial period. In the second phase of insulin response, gradual increase in insulin secretion occurs that lasts about 60 to 120 minutes. That means about 2 hours. And this stimulates the peripheral insulin dependent tissues to take up the glucose so that the blood values of glucose remain normal. During the second phase of insulin response, about 80 to 85% of the glucose metabolism occurs in the muscles during this time. Slower release of insulin in about 2 hours allows the body to respond to new glucose coming from the digestion and maintaining the blood glucose levels. Okay, now move to role of amylin. Amylin is a naturally occurring hormone that is co-secreted with the insulin through beta cells. It is believed that most patients who have diabetes will have a relative or complete lack of amylin. Basically, amylin has three major mechanisms of action. First is the suppression of post-meal glucagon secretion. Post-meal means after meal glucagon that increases the glucose levels, and then regulation of the rate of gastric emptying from the stomach to intestine, which relatively increase satiety. Satiety means fullness, don't need any food more. And the third one is the regulation of plasma glucose concentrations in the bloodstream. Now move towards the impaired insulin secretion. Normally, a properly functioning beta cell is able to adjust the insulin production to maintain the normal blood glucose levels. If the beta cell cannot work properly, then hyperinsulinemia occurs. That means the high blood level in the insulin. And this will be the early finding of the development of type 2 diabetes. In case of hyperinsulinemia, more insulin is secreted from the beta cells to maintain normal blood glucose level, and that results in inability of pancreas to produce sufficient insulin to maintain normal blood glucose levels. The resulting hyperglycemia will be more due to insulin resistance because no insulin is being produced. This causes the pancreatic burnout in which beta cells lose functional capacity. Impaired beta cell function results in reduced ability to produce first phase insulin response sufficient to signal liver to stop producing glucose after a meal. Because the liver is synthesizing glucose from glycogen that is stored in it, and this will not stop, and the blood glucose level will be higher. As the diabetes mellitus progresses with the age, most of the people suffering from diabetes type 2 will lose all the cells function and require exogenous insulin to maintain normal blood glucose levels. Now moves toward the insulin resistance. Insulin resistance is the primary factor that differentiates type 2 diabetes mellitus from other forms of diabetes, for example, type 1 diabetes. Insulin resistance may be present for several years prior to diagnosis, and this can progress throughout the course of the disease. Mostly, the resistance to insulin occurs in adipose tissue, skeletal muscle, and liver. Due to insulin resistance, liver poses a double threat because the liver becomes non-responsive to insulin for glucose uptake. You can remember the first phase insulin response, and in that case, hepatic production of glucose after the food will not cease, and this will lead to elevating fasting and post-meal blood glucose levels. Now move toward the metabolic syndrome. There are some complications that are associated with the diabetes mellitus. Insulin resistance has been associated with a number of cardiovascular risks, including the abdominal obesity, hypertension, dyslipidemia, hypercoagulation, and hyperinsulinemia. Hyperinsulinemia means more insulin in the blood. Hypercoagulation means high rate of coagulation. The clustering of these risk factors has been termed as metabolic syndrome. Widely used criteria to define metabolic syndrome were established by National Cholesterol Education Program Adult Treatment Panel 3 guidelines. Following are the five components of metabolic syndrome. First is the abdominal obesity that is related to men and women. In case of men, the waist circumference if more than 102 centimeter, then you have the metabolic syndrome. For women, waist circumference more than 88 centimeter. Number 2, triglycerides more than or equal to 150 milligram per deciliter. And HDL cholesterol for men less than 40 mg per deciliter, and for women less than 50 mg per deciliter. Fourth is blood pressure that should be more than or equal to 130 by 85 millimeter of mercury. Number 5 is the fasting blood glucose more than or equal to 100 mg per deciliter. Next is the incretin effects. When nutrients enter the stomach and intestine, incretin hormones are released, which stimulate insulin secretion, and this phenomenon is called incretin effect. Incretin effect was validated by measuring the C-peptide and insulin response to intravenous and oral glucose loads. GLP-1 and GIP are the two major incretin hormones. GLP-1 refers to the glucose-like peptide 1 and the GIP means glucose-dependent insulinotropic peptide. GLP-1 is secreted through the L cells of the ileum and the colon primarily, and the GIP is secreted by the K cells of the ileum. When nutrients enter the stomach, then GLP secretion is caused by the endocrine and neural signals. In this way, a glucose-dependent release of insulin occurs, and the dipeptidyl peptidase 4 enzyme cleaves the GLP-1 rapidly to inactive metabolite, so that glucose level can be increased in the blood. Much of the research on glucose-lowering products involved the prolonging the action of GLP-1 because GLP-1 decreases the glucose level in the blood. Other glucose-lowering effects of GLP-1 include suppression of glucagon, slowing gastric emptying, and increasing satiety. That's it for today's lecture. Next lecture will be on the clinical presentation of the diabetes. Thank you for your patience. Kindly subscribe my channel, like the video and press the bell icon for more updates. Thank you.